renewal of the Medicaid transformation project. And these are valuable sessions because we finally get to talk with people one-on-one or as a group about what we're doing and where we're heading. So I just appreciate the invitation very much. And I should probably clarify that, yes, I aged into qualifying for the Boston Marathon. If I could, we could go to the next slide and talk a little bit, it just kind of grounds us a bit on the timeline that we're in here. Up to this point, we've spent the last 12 months working with ACHs and managed care organizations and other groups talking about what we would want to have in a new 5-year waiver. And I think, as most people know, we're finishing up the 6th year of the current waiver. Our federal partners, the Centers for Medicare and Medicaid Services, give us an opportunity to ask for another 5 years waiver. So we have that opportunity to present some transformative and innovative material, different ways that we'd like to run the Medicaid program for the state. And it's a bit of a challenge because we have to project so far in advance, so what we would like to do. And so I think, but it's the opportunity that we get, and we definitely want to take that. So right now, if you look at the second green bullet from March to April there, we are definitely in the period here where we are coming up to the public comment period. That's actually the third green point there, April through May. And we will be wrapping up the application this week, hopefully getting a final draft together that can go forward for public comment. And that's an important step for us, and it doesn't really change the conversations that we have every Monday with John and his colleagues. I mean, those continue, but it does change somewhat that we make sure that we have a 30-day period where the entire public in Washington State can review the draft application we've come up with and give us comments, and we stop changing the draft and put it out there so that everyone can see the same thing for the same 30 days. We are still focused on submitting the application to CMS July 15th of this year, and of course that then begins a process of negotiation with CMS. We will have plenty of discussion with CMS back and forth. We expect to be sharing a lot of that with John and his other executive directors and the ACHs as we go forward, because a lot of those questions are statewide questions and we can't answer those ourselves at Healthcare Authority. We need to continue to engage people and talk about solutions. So John, if we could go next. It's a little bit more on some of the aims that we have here. And one of the things that you'll see here is that we set up that we want to continue to do whole person care. The second point, we want to continue to work with communities. And the third is we want to be a transformative payer. And we want to have integrated health and equitable value-based care. And what you'll see in these points here is that the word equitable is in each and every one. And one of the areas that we did not succeed in the last 6 years is in reaching everybody in the community. In fact, we worked with the ACHs on some transformative delivery system changes and work with community-based organizations, and it really showed in results for chronic illness care. It showed a lot in the results for substance use disorder and the opioid epidemic. And the data trended in the right direction. But what also we saw is that consistently people of color were lagging behind in those results. Two groups in particular, Black individuals and American Indian Alaska Natives. And so we figured that we were proud of the work that we did, but we also know we didn't reach everybody. And so what you'll see when we talk about the renewal is that we have some specific programs so that we can try to make sure that we get to everybody this particular time in the communities. And if we go to the next one, we're going to have to talk about the goals of the renewal. And we want to talk, we've organized the document more in terms of goals. And so we've lumped common initiatives into the goals here. And I'm going to go through this fairly quickly because we want to talk mainly about the third area because that's where most of our work is with the ACHs. But we want to expand coverage and access to care, ensuring people get the care that they need. And we have 3 items there: continuous enrollment at age 6, reentry coverage for people who are incarcerated, expanding postpartum care coverage. All of those were either suggested or directed by the legislature. And so we will be responding to those. And then, of course, our work that we're doing with substance use disorder and mental health in facilities, known as IMDs, where we can continue to pay for that care, but do so with federal assistance. And then advancing whole person primary preventive care, we have primary and behavioral health care integration assessment. We did integrate for coverage. We'd like to assess how to integrate at the clinical level better now. And then with long-term services and supports, that's with our partners at DSHS, and they have come forward with several innovative policies for the renewal. So that brings us down to accelerating care delivery and payment innovation focused on the health-related social needs. So there's 2 big areas that we've worked with the ACHs on. And before I get into the 3 blue points down there, but health-related social needs, those are all of those services that we work with community-based organizations on to address social determinants of health. All those non-clinical services that we know improve the health of families and communities. These are things like transportation, food, all those items that the clinicians have told us for years, could you please provide this through the Medicaid program to individuals, because that is sometimes what they need more than anything else. And then another concept that we've worked months developing with the ACHs is what we're calling the second blue point there, community hub model. And I want to talk a little bit about that because we've used the term hub for about 6 years now, and we've actually used it in terms of talking about a particular form of a hub, which is sometimes the Pathways Hub. And we realize we're using the word community hub again, but we mean something entirely different this time around. We're not being specific about the type of community hub that we're looking for each of the ACHs to develop. But we still want to build out this community hub model. And so what we've done there is we want to build out that model so that we can support those health-related services like food and transportation, and then also support the equity investments that we were just talking about that the Healthcare Authority would like to develop jointly with the ACHs. So the first blue bullet there, community convening and capacity, we are going to need a workforce to do this, and most of that is from community health workers. And so we are also putting forward a presentation to our federal partners at CMS that they help us with that, affording that workforce. We also want some form of community convening, and capacity building through the ACHs to carry out the work that we need. And then finally, foundational community supports. And that's an area that supports housing and employment, 2 very important health-related services. So John, the next one, we go in a little bit deeper dive on number 3 here. And if we could go to the next bullet, this is where we want to talk a little bit more about health-related services. So we deliver health-related services in a fashion today through managed care organizations with the Medicaid program. It's really done on an almost one-to-one basis, and authorization has to occur basically for one individual to do one kind of service. We're finding out that when we do it, it's effective, but we need a way to develop more of a framework, more of a conveyor belt to the community that we can identify the services that are most predominantly needed in the community and make sure that we deliver those at a much larger scale than we do today. And we're really copying what has happened down in California on doing this, where California put together a list of services and said, these are the services that we would like to would like to see delivered throughout the community. We would like to have it in a sense pre-authorized, recognize that these services need to be done continuously and not always asked just for one-to-one approval and then move out and do it. But there's a recognition that the service is something that is part of the Medicaid program and it's just delivered as a course of services performed on a daily basis. And the way that we would like to do this, and this gets into a little too much Medicaid terminology here, but it's called in lieu of services. And as I said, we do this today, but we do it on a one-to-one basis, and we do it through managed care organizations. And what we want to do is just enhance that program. And if we put forward a proposal to CMS, it will be in the form of saying, here is a list. We've identified all these services. We believe these should be delivered to communities on a continuous basis and not have to be discussed and approved on a one-to-one basis, and that they're recognized as part of the services that we perform, and then we'll perform them at a much more predominant level throughout the community. But we also need to put something together for the fee-for-service community because not everybody receives their Medicaid services covered through managed care organizations. So we will do that as well. And so our idea is to do this with MCOs and develop a partnership between ACHs and MCOs and to perform those services through the coordination of a community hub where there would be screening and referral, and the hub community network can be used, like I say, to develop those services at a much larger scale, and to have those services then coordinated. The other thing is we want to explore some strategies to work collaboratively and leverage the MCO and ACH strengths. We feel like we work with two very good partners, the MCOs and the accountable communities of health. They both have strengths in how they perform with the Medicaid program, and we can do a better job of leading a group that can develop a much better way of working together to support our customers and have a much better, as I say, predominant way of delivering health-related services throughout the community. And then it's also possible that we may not be able to deliver everything through the managed care system. And if that's the case, we will do that through 1115 authority, through the waiver authority, and have a way of funding those services as well. And of course, we will, explore some ways to deliver these services to the fee-for-service population as well. So if we could go to the next slide, I think we're going to talk a little bit more about this partnership. So we have, in a sense, what we have here is health-related services. And then at the top line there, we'd like to use the in lieu of services format. We also have the fee-for-service and waiver health-related services should we need to. And we will need to somewhat for fee-for-service because not everyone receives their care through managed care. And as we negotiate with CMS, they may want us to have some of the health-related services done through waiver payments, and we'll just be open to that. And then the third row there, the foundational community supports, or FCS, is those services that we're already delivering in the waiver for supportive housing and supported employment. They just help people retain housing and help people gain work and retain work. And we want to continue those services as well, and then coordinate better with that program through the community hub. So the health-related services definitely receive support through ACH implementation of the community hub. The ACHs will lead that network development and capacity building across community organizations in alignment with the community hubs. And of course, then we want to test some ways to work with MCOs and ACHs to have that streamlined contracting and reporting ability. So again, we're looking for a tighter working relationship, a more partnership-oriented approach to how we run the Medicaid program, because managed care organizations are terrific at certain functions. We know ACHs have proven themselves in their ability to work with community. We just want to take advantage of both sets of organizations so that we can deliver these services at again, a much higher scale than we do today. On the next one, I think, John, if we could go past this one, we use this for certain audiences. It's really a regulatory framework we borrowed from California. I think it gets real deep. Thanks, John. So these are some of the health-related services menus that we would like to get set up in Washington State and negotiate this through our partners with federal CMS. As you can see, these are all the kinds of things that address those social determinants of health. Again, all of those non-clinical ways that we stay healthy. And I have to say that, for years, doctors and other clinicians have simply said, please, if you could find a way to deliver these services to individuals, and especially in the Medicaid program, please do, because sometimes that is what somebody needs more than the services that I'm bringing, as my clinical expertise. So again, housing transition navigation services, jumping down several, you see rehabilitation programs, nursing facility transition programs to assisted living, jumping all the way down to the final three there, you see asthma remediation. Sometimes a lot of that is just an investment in somebody's home that can improve the kind of care that somebody gets who has asthma, so we're not continually going back to the emergency room. And the investments can sometimes be so minimal and actually very inexpensive compared to a stay in the hospital or several trips to the emergency room, over a several month period. Medically tailored meals, especially for people with chronic illnesses, very important, and the health impacts are proven out. And again, it keeps somebody living with the condition and healthy, as opposed to, again, making trips to the emergency room. And then sobering centers, which we're going to change that name to stabilization centers. Again, people just need places to go where they can become stabilized. We don't need to rely on the justice system. We don't need to rely on emergency rooms as well. If we can have us pay for a service like this, again, that is much more appropriate to what somebody needs, is very cost effective, and to the alternatives that we're using today. On the right side there, we have some of the other services that we believe may not be available to us through the in lieu of services system. And we anticipate that we may have to negotiate these with our partners at the Centers for Medicare and Medicaid Services to talk a little bit about how we might pay for these with the waiver dollars. So those are just some of the things that we will put forward. You'll see that in the application when it's made available for public comment on May 12th. And then next we can go to the next slide, John. I think we're going to talk a little bit more about the health-related services principles. Again, we want to continue to work with ACHs to build out those community-based organization capacity and to take on new contracts and services. And we plan to have that capacity building funds in the waiver. We want to leverage community information exchange, CI infrastructure where it's been built, and make it more robust, and of course have a strategy that connects the community information exchange throughout the state. We also want to ensure that we have shared accountability for health-related services. And again, this is where healthcare authority needs to leverage the strengths of ACHs and MCOs and build a much tighter relationship between managed care and accountable communities of health. We'll always need to have clear measurement and evaluation strategies. We'll have to try to minimize variation this time so that we can create some administrative and streamlined effectiveness with our providers, and so people are not burdened so much just to carry out these services. And of course, as much as possible, minimize the administrative complexities and have some strategies that we work out with managed care organizations and accountable communities of health to streamline the contracting and the payment process. And then next, John, I think we're going to get into the hub, the health equity programs first. But on the health equity, we have. Excuse me, John. I'm finally in the office now, so I'm seeing people I haven't seen in 3 years who are waving at me. But we have, what we'd want to do is we have regional equity investments. And again, what we would like to do is understand that we are not going to reach everybody in a community if we don't set up a simple system with structures and some sideboards to ACHs on how we would like to carry out some health equity programs. And we've talked about this in the application that's coming out. We hope it's just a simple form of leadership from the healthcare authority that reaches out to accountable communities of health to say, let's work together to develop programs. It may be as much as finding new ways to deliver health-related services, but in ways that reach everybody. And we don't feel like this is going to happen if we don't make a priority out of it and ensure that we make an attempt to reach everybody in the community. So we will have equity funding. It will be, again, delivered to ACHs. We'll work hand in glove with ACHs on how to develop those programs. And then that way invest in community-based approaches that improve the health equity of all of the Medicaid clients. And then on community-based care coordination, again, we would like to do this through the community hubs. These hubs would, be regional and managed by ACHs. There's already been some coordination with Department of Health on Care Connect Washington. We want to make sure that where that has happened, that we leverage the investments to date. We also know that there's some core regional infrastructure for communities on convening and capacity planning, whether ACH is working on a community hub at the moment. There's a lot of this kind of work that goes on that is that we want to take advantage of, where relationships with the community-based organizations have already been put in place. And the third blue point down there is something that we'd really like to make a priority on with the community hubs, and that is providing certain populations of emphasis with even higher touch care coordination for those community-based services. And one of the populations that's really come forward is that reentry population from incarceration. And what we'd like to ensure is that we really help those people transition back into the community. There's a lot of evidence that there is the need for this. We are losing people sometimes within the first week or two of reentering, simply because we don't have the coordination through the Medicaid program just for an individual to get right back into the services that they need, especially someone with who's been having substance use disorder, opioid treatment that is needed. We want to continue those services and not lose touch with individuals. So that's one of the ideas that we've had. We want to make sure that the community hub is available to help with health-related services, but we also want to make sure that there is a care coordination for these reentry populations of emphasis, such as the reentry population, so that we have a better care coordination system. And then, of course, we have ACHs convening with system capacity and workforce developments. We'd like to have workforce training and development done through the hub, because we know that this takes people. We have to have a better and stronger workforce of community health workers to carry this out, and we'll be requesting that from the federal government as well. And then the capacity building. I think just no shock to everybody here, just requires time. We don't plan on launching these policies and programs in January of 2023. We want to use 2023 to invest in the development of the hub, to invest with community-based organizations to help them learn how to coordinate with the hub and have a more effective coordination of these services. And of course, we need some time to work with managed care organizations and accountable communities of health to develop a relationship that leverages both of these groups. So I think, John, in the next one, we're going to talk a little bit about the hub functions. And as I mentioned earlier, we want to make sure the hub is there to engage with all the Medicaid enrollees. So we'd like to make sure that anybody can go to the hub. It should have many ports of entry to the hub where someone can be identified and screened for any health-related services we need. That's the minimum that we would like to see happen with the community hubs. But we also want to make sure that we establish the networks with community organizations, which most ACHs have done to a certain degree to date, that we have some kind of connection with the patients with these community organizations. And again, some would be high-touch approach and develop a comprehensive community care plan and try to coordinate the coordinators, because we have caseworkers on the clinical side as well as the non-clinical side. So this is where for certain populations of emphasis, we'd like to have that high-touch care coordination. And as we work through that with, say, the reentry population, we'd like to identify additional populations that we could work through these high-touch coordination efforts. And then we want to make sure that we have follow-up, that we do track the outcomes to ensure accountability. And then we have a few more functions on the next slide that, or the roles discussions. Again, what we see is that there are some expertise that we'd like to take advantage of, and we know that MCOs work well right now in delivering health-related services, and they do have community connections with people, but they're also very good at doing the payment and have community-based workforce. From the ACH side of this, we have a delegated community-oriented health-related services group. We'd like to see if there's some ways that ACHs can play a role in testing payment strategies, ways that would reduce barriers, create efficiencies, and of course, possibly even have some community hub payments for community partners as they carry out the services, so that we reward those who perform the work. Again, care coordination, we still see MCOs as doing the clinical care coordination, and ACH is continuing to do that community-based care coordination that is so essential for making sure that we have, feedback loops. And we know that if we're referring somebody to a food bank, that they actually arrived and received something. And then again, we'll have to have some kind of community information exchange or CIE and data. And we're working on that at the Healthcare Authority side to try to bring forward that information technology undergirding that's going to be needed for community hubs, and make sure that that is developed and a CIE strategy is rolled out throughout the state to support the kind of community hub operations that we'd like to see. And then John, next, I think we talk a little bit more about just open up for some questions here, but usually when I get here, John, I'm just open to advice, comments, any clarifying questions if people have them, but we are still very much in the listening mode, even as we are wrapping up the application for the official public comment period. And of course, this discussion will go solidly through the end of the year. So happy to hear from people now and all the way through the end of December as we continue to develop the application and negotiate it with our partners at Centers for Medicare and Medicaid Services. So thanks, John. Thank you. Over to you, and glad to listen or comment.
Let me ask, is fresh in board members and community and staff members' minds, so I would open this up to anyone who wants to join. When you look at the questions that Michael has on the screen, and you think of North Central ACH's role into this, what things come to mind? What comments come to mind that you think that we are well positioned for, or what things do you think you'd have some concerns about?
This is Ray. I feel like we've made a lot of really good striving and work especially with healthcare during this transformation. I think we've created a fantastic cultural change with this work, but I am still concerned about the sustainable infrastructure. And as you know, COVID kind of threw a big bat at us too with that and showed all our weaknesses. But what I am concerned about most is having a coordinated platform to communicate with our community partners or community-based organizations to do care coordination, because you can't rely on just one sector to take care of the community. We all have to do it together. I know that has been tried to be done in multiple states with, frankly, failure. And so between the health exchange and no real infrastructure to do care coordination, those two things really, to me, can only happen from the top. It's got to happen from the state. It will never work unless you guys build it and make everyone use it, for the lack of terminology. The other thing is I still have not seen policy change from the health authority. There is a lot of work that we've been doing that's been being paid for by this funding, and to be sustainable, the healthcare authority has to change. And I see very little movement. There's been a lot of practicing and trying to trial and error to try to figure this stuff out. But now it's time to change some of those policies. There is still not funding for community paramedicine. I could keep going on to lots of different other areas that we can work on, but where we meeting halfway, that's the other thing we need to know. So you need to add policy on there.
Okay. Yeah. Thank you, Ray. And let me make two comments on this, if I could. I agree with you on the coordinated platform, and it does have to come from the state. And we need to have a form of a community information exchange statewide strategy that brings everyone together with an agreement on how we're going to work together to roll this out. So the healthcare authority received some money to start looking into how to do a statewide community information exchange strategy. We received $1 million to do that and to work with a consultant. And unfortunately, it's not to put the platform into place, but to develop how we could do it, and then to come back to our state legislature and make the ultimate recommendation that here's how we would like to go about putting community information or exchange, or what you called a coordinated platform, in every community throughout the state. It'll take much more than the $1 million that we asked for. And we plan on developing that package this year and then bringing it forward again to the legislature next year. So this year, we actually tried to go forward with the legislature and request much more than $1 million. We requested $15 million to do two things for that coordinated platform. One is to actually select a vendor that could be used in communities throughout the state. And the other thing is to develop ways to link the systems and take advantage of the infrastructure and that has been put into place already for community information exchange. So I agree with you. That needs to come from the state, and then it needs to be done in a way that builds that coordinated platform at the same time that we're working with URACH to put forward and have that capacity building with the community-based organizations and figure out payment mechanisms with you and the managed care organizations. So we need to get that approval. We need to move forward on that. So I'll be keeping John and all his colleagues informed as we go forward on that. But it's not there yet, and I agree with you. It needs to be there. On the policy change, I could probably listen a lot more about what it will take to, like you say, the community paramedicine. But let me just mention one one decision we made that may help with sustainability, and that's the part about the in lieu of services. And I know it's Medicaid terminology and minutia in the middle of a presentation, but it's the reason we're going forward there is that we're already performing those services through the managed care organization, and in CMS's viewpoint, it's an accepted way to perform food and transportation for individuals. And so by doing a system that's already in place and building on it, we run a much better chance of sustaining those health-related services throughout the state. So we're trying to, every time we can tack on to something that's already working, it improves how we, improves our opportunity for sustainability. And so that's hopefully a policy decision that will pay off in the long run. In the short run, our goal is to, again, leverage what we know managed care organizations and ACHs do well, and make sure that we have a system that delivers those kinds of services that address those social determinants of health. So Ray, thank you. Those good comments for me to keep in mind.
Michael, could I ask a question as well? This is Mike Tuggy from Confluence Health.
Yes, please.
Yeah, so just to make sure I understand the definition of the MCOs, are the MCOs you're referring to are managed care plans like Molina and coordinated care, or are you talking about the healthcare delivery systems as well in that definition?
Oh, thanks, Mike. Yes, specifically, I'm in this in our package to CMS, we're referring to the managed care organizations, Molina, Coordinated Care, AmeriGroup, Community Health Plan of Washington, and the fifth one that's escaping me right now. And so,
okay, because I guess my concern about care coordination or case management of complex cases is that I think there's the reason why there's been a lot of failure in that work that's trying to be managed by the MCOs is that the funds don't trickle down to the actual clinics that are delivering that care, or the health systems that have the case managers that are embedded at the clinics, because the effectiveness of that care is so much on the patient's ability to engage with their care team. And so if there is funding that's directed from CMS through those MCOs, there needs to be as much of a direct pass through as possible. That's just my sense of my worry is that, if they take 20% of that funding off the top to support the MCO infrastructure, it's not getting down to the clinics where that care is much more effective when done by the care team with an embedded case management for care coordination and complex care management.
Mike, thank you. Let me bring that forward with some of the colleagues that I work with on the managed care organization.
Yeah.
And I've heard this comment. Did you say you're with Confluence?
Yes, right. Yeah.
Yeah. I think it's
even within our system, when we've tried to use case managers that are not closely tied to their primary care teams, their effectiveness drops down dramatically. And so we've learned from trial and error that you really have to have people that are close to home, who are in the same town or community, to be effective with those complex patients.
Okay.
And Mike, I may comment to one of Michael's earlier slides, especially around the partnership with MCOs and ACHs. I think that's why it's important to really have both involved in this work, because especially at a regional level or one provider or one CBO level, it can be really hard to work and cooperate with 5 MCOs. And so really we have that opportunity to help streamline that and manage better, and really provide kind of a streamlined voice to the MCOs from all of our partners to put,
Right.
accountability and pressure each way on them as well.
Thank you,
Mike. Yeah, thanks, John.
Another
This is Molly.
Oh, go ahead, Molly. You first.
I was just going to say that I had a long chat in there just about spend down. I live in a rural elder senior population community, and we don't have Medicare Advantage programs here. We are dual eligible, and they're all stuck in a spend down. So they do not qualify for any Medicaid programs, and their health has suffered, and I have actually seen some tragic events happen because they did not have Medicaid coverage. I don't know if CMS has an idea of raising that income level of the Medicare, Medicaid patients to match just Apple Health, because at this time they don't match.
Yeah, Molly, one of the places that we skipped over quite quickly when I talked with ACHs was about long-term services and supports, and our colleagues over at DSHS are, I think, doing a very good job bringing forward two policies that I think that may help in the area that you're talking about. One is just having a system of presumptive eligibility, and we're trying that with the waiver today, and it's worked quite well over the last 5 years. And so they will be proposing to our federal partners at CMS that we do that across all of the long-term services and support system in Washington State. And at the Healthcare Authority and Department of Social and Health Services, we know we're asking for a big policy shift from our federal partners. So we do expect that one will be very difficult to negotiate, but there's all the reason in the world to do it. And the other one is some coordinated personal care that they have in mind is a more effective way to deliver the services. I apologize. I skip over that so quickly just so we can get into goal number 3, because that's usually where most of the ACH work is. But you know, with members of the board around the community, we find that all of these policies touch one of you in some way. So hopefully, and that won't solve all of the spend down issue, but at least those are policies that are going in the right direction.
Go ahead, Peter.
So Mike, as I look at the slides on in lieu of services and health related services, it looks to me like a lot of funding may go to places it's never been before and touching a lot of different agencies, community-based organizations, et cetera. Can you talk about how you envision the role of the ACHs in both, setting up the infrastructure, vetting the organizations involved, et cetera, versus direct contracting through the HCA? Where is the ACH in this milieu?
Yeah, Peter, you're asking the very next step that we need to dive into, and I really appreciate that. Let me just kind of mention a couple things, and then because that's a deep conversation that could go on for quite some time.
Right.
I agree with you 100% that we are going to be either asking organizations who have never been funded to do this, or organizations who are funded to do it now on a much smaller scale, and we're going to ask them to scale up quite large to do the level of services that we think the community needs. So what we've been talking with John and his colleagues about is developing an operational work group so that we can start talking about the roles and define roles, especially between the managed care organizations and the ACHs, and to also talk about what the responsibilities should be. So for example, just taking one small piece here, just the payment of the service. One of the things I need to mention about in lieu of service is that it's optional for an MCO to offer them, and it's optional for a Medicaid client to receive them. But most of the time people do, because the services are valuable and they're highly cost effective. So that's why we want to see it done more often. But obviously the MCO will have to make the payment. But there's a lot of work that an ACH could do to know about the perspectives and the priorities within the community, what is needed most often, and where to target populations. Also, just setting up the service, being able to confirm that the service was carried out. And then possibly we may even have some form of payment to a community-based organization for carrying out this, for closing the loop and making sure the service is performed. But we have to work all that out as you're talking about, and that's why the capacity funding is being requested from CMS, and why we're also letting CMS know that don't expect us to be just hitting the ground running in January 2023. And then I think the other part to this is we want to make sure that we build out the hub, but we also want to work closely with the community-based organizations. And that's actually a lot of the comments that I get when I talk to any of the boards of the ACHs is, don't forget that you're going to have to work with the people who are actually performing these services. And you have to bring them along, because these are not organizations that work this way today. And you can't just build the hub with the ACH and then it all just flips a switch and it all works. You're going to have to bring along this whole network of organizations that's used to receiving money in a different fashion, performing their work in a different fashion. And so we've, again, we'll be making that point with CMS. We've already made that point with CMS when we talk to them monthly and try to give them a sense of where we're going with this application. So I admire the question, Peter. It's a very big question. If there's anything else that I can address about it, I'll give it a shot. But all of it is then the work that comes after we submit the application. We are not going to wait for the application to be approved. We want to start working out the operational roles as soon as we can.
Thank you.
Peter, I may jump in because we shared just some thoughts even with Michael prior to presenting, that the term community hub can mean a number of different things, and especially in our region, when we tried the Pathways Hub and decided to discontinue it, it can really have some hesitancies come up on the sense that we would be going right down that direction. Really, again, I would reference what Michael said earlier. Really, is the ACH role is helping to support that building infrastructure, community-based care coordination, that then health-related services can really insert itself into, and also ensuring that those things are well aligned. And so the goal ultimately would be to build that supporting infrastructure, that community-based care coordination organizations, the MCOs and everyone can really work together in to deliver this appropriately. I will say every ACH is supportive of the intent and the concept. The nice thing about the waivers and the way that HCA has worked with each of us, we all can also ensure that that work fits with some of the unique components of our region as well. So make those small tweaks within those big concepts to align with the way we do it in our region.
Thanks.
And I just want to shout out, I know Caroline's been doing a good job working with CBCC partners and identifying some of those components and really getting an initial step in some of these discussions at our local area. And Caroline, I don't know if there's anything you want to comment above that.
I think in a nutshell, when we discuss this concept of a community hub, what we're gravitating towards is less of a centralized entity, the way things were envisioned under the Pathways Hub, and more thinking about an infrastructure that enables a connected system. So it's not one entity, it's an infrastructure that enables a system. Because we have a variety of partners across our region that are already connected a certain way, and it is so disruptive when you ask them to rewire all the connections. And so that's one of the things we're trying to figure out. How do we not completely rewire existing connections of partners doing this work? And also, how do we do this in a way that isn't just Medicaid specific? And the billing is something that, I feel like there's a paradox when I see those the health related service bullets. We heard Ray say we need to find ways to sustain these services. I absolutely agree. But the paradox is that when we sustain it through billing of discrete services, we create this administrative burden that just slows, like just really burdens the system and sometimes sinks our partners, including small ones, like the ones that Peter called out, the ones that haven't been involved in this work. So that's the part that we're making sense of as a region. Like, what does this mean, and how do we need to structure this in a way that it doesn't harm our partner network? And there's still a lot to flesh out, but I guess those are some initial just thoughts for the board members to know that these are the discussions we've been having internally as we try to make sense of what we're seeing from the state conversation.
I appreciate the sensitivity about that. Obviously, a lot of work, a lot of thinking's been already done, so thank you.
Michael, I have a question about, you mentioned the CIE, the $1 million that were obtained and the thinking that's going into that. At what stage do we as ACHs get to provide input about the way that's shaping up? Because to be honest, it's a bit of a black box for me, but it's very relevant to this work. So any thoughts on that?
Just a couple, Caroline. First, want to thank Senator Warnick for being here and the legislature for funding us to look into this, and thank you so much. And we are happy to receive the money that we received, because what we're doing, Caroline, is we're taking the first steps that we would have taken even had we received the $15 million. So we're very pleased with the $1 million. A couple things that we're going through right now is let me just mention one very important part which will involve ACHs, and that's that part of the challenge that the Healthcare Authority has in requesting the money is that nobody yet has a very good look at what the investments have been to date in different kinds of community information exchange. And so one of the first things that was asked for in giving us the $1 million that we do some, I'll just call it a landscape review of what's going on in the state. There has been some investments that have been made that done differently in different counties to fit the needs of those counties. And so that's the first step that we're going to work with the vendor on, is just describing where we're starting from and what kind of investments have been made. And of course, we will need to work with each ACH to do that. The next step we want to take then is to do some kind of a assessment of what is the possibility of doing some kind of community information exchange strategy throughout the state. And we'd like to, again, work with a vendor on this so that we get an independent assessment of where we're at. Obviously, we see community information exchange as a need throughout the state, but we need some expertise inside the organization at Healthcare Authority and outside the organization to work together to come up with a true assessment of where we're at and what's possible for the next steps. Because as much as I would like a vendor to come back and say, here's a recommendation on how you can go forward, what I want is an independent, honest assessment of what's possible. Because it's sometimes hard to accept that advice from an independent vendor, but that's why we hire them. If they say, this is, you're not quite where you think you are, or it's a bigger step than you are envisioning to put something like this together. That's hard medicine to take sometimes when you want to do something, but it's a whole lot better than crashing and burning, say in 2025, investing a whole lot of money in something that you just kind of took as an idea. So we want to take a serious look at a landscape review and a very serious look at assessing what are the possible recommendations where we could go forward. And is it possible? What are the risks? So that's what we're trying to get to this year before the next legislative session starts.
And Michael, I believe we're a little over time, so I think we're going to wrap